So we are going to talk about from vertical to horizontal experiences and recommendations from integrating SAM treatment to health. So this is a little bit the presentation outline. I'm just going to set the context and talk about the background, and then ask Maureen to do the rest of the job. So, in setting the context, we wanted to present some of the notions that we are going to talk about in the next 10 to 15 minutes. And some of them are not maybe that usual for us nutrition people, but are very common for the health actors and environment. So universal health coverage is something that everybody's talking about today in the health environment, and scaling up SAM management is pretty much sharing the same vision. Well, it's going to the same goal. Now, this presentation is going to focus on the design and implementation, how we are going to achieve scaling up SAM management with the vision of achieving universal health coverage. The other question that we are going to raise, perhaps, and later on in the discussion, I hope, is how much are we not only part of the solution, but probably as a nutrition community part of the problem in not reaching scaling up. And then we wanted to go a little bit more into the details of what health system strengthening means. We are not going to do a lecture, and I'm sure most of you know about health system strengthening, but it's as such, this notion is not new. It's quite old, but the fact that it's divided into 6 building blocks is very new. In fact, it's younger than CTC concept. It's from 2007, and here you are going to see all these signs regularly in this presentation. The first one is about governance, one of the first building blocks, governance and leadership. The second one is financing. The third one is service delivery. Fourth one is human resources. You see the fifth one, it's supply, drugs and medicine and products. And the last one is health information system. So health system strengthening can be seen through these 6 building blocks. And today, when we are in this presentation going to talk about integration, integration can mean a lot of things. It can mean multi-sectoral integration between different ministries. Here we are going to talk about the institutionalization of SAM treatment into health, into Ministry of Health. So, yeah, next one. So you all know about what happened in the last 25 years with the SAM management. And in Washington, in the meeting that I think it was Steve Collins or maybe André talked about this morning, in Washington meeting, Carlos Navarro did a presentation talking about the 3 revolutions of SAM treatment, from inpatient to outpatient to community and integration into health system. So lots of things happened and there was a lot of improvement. But now the challenge that we are facing is that although we had all these improvement, we are facing still a very low coverage. Why that? It's, well, at the start it was pretty much implemented by NGOs. Now ministries of health are more and more taking it over. But what makes it so low coverage? One of the conclusions of the evaluation that were made is that the state of the health system, if it's weak, it doesn't allow this coverage to raise and the SAM management to be available. So there is a need to strengthen the treatment of SAM as a disease and to strengthen the linkages between nutrition and health. There is something very obvious in this meeting, for example, is that we are still among nutrition people. And I'm wondering quite a lot where these health people are, because, and that's where I go back to this, are we not part a little bit of the problem? Don't we want to keep our own baby with us, like SAM management, it's our own baby? When do we push it to the health system? So that's pretty much what we are going to talk about. And in doing so, we can learn a lot from the global health initiatives, you know, these Gavi, PEPFAR, and Global Fund initiatives. They realized many things in implementing their initiatives, but 2 very important things that these vertical approaches can have adverse effects on the health system. It can weaken the health system. And conversely, weak health systems are bottlenecks to these disease approaches. So how do we go around that? And a sentence that I've read in a very new article, in an article that is really recent around health system strengthening and how we go around that, is there is this sentence that I like. We are creating islands of excellence in seas of under-provision. So this is something I think it's food for thoughts for us. So the next slide, and that's going to be my last slide, and I will give the floor to Maureen. It's what is vertical and what is horizontal. So I think it's pretty much talking for itself. Vertical is having maybe health resources at the same point of delivery that are dealing with different types of people that are supporting them, or different reporting mechanisms, or different ways of, or different policies, implementation plans. While horizontal is to have a global package that you deliver at the point of delivery with these people that will deal with this unique package. So this is where I'm going to leave the floor to Maureen.
Thank you. Thank you, Ando. I'm going to share some practical experiences that I've had in relation to SAM treatment institutionalization into the health system, and we're really trying to use it as an opportunity to strengthen the health system. And just to clarify, it's not to say that there aren't prevention activities in nutrition to be integrated into the health system, but here we're going to focus more on treatment because it's the topic when a child is already diagnosed with SAM. So I'm going to go through the 6 building blocks. I'm going through the 2 most recent experiences I've had. One was Nigeria. I was there for a couple of years starting up. And I'll just go through each block. So in terms of governance, there's very strong government support in terms of child health care is free for children less than 5 years. It's a very state-based system. So states do get to choose what they adopt or not from the federal government. I was working in Yobe State, and there they did adopt this less than 5 years. They also were one of the only states in 2012 to include nutrition as part of their state health plan. And in general, there are guidelines that have been developed for outpatient. Inpatient are being updated, but still not complete. And since it started in 2009, authorities and communities have been quite committed. Once they're provided with evidence of what is SAM and what can be done about it, they've really been committed to engage and really try to achieve and support the treatment as much as possible. In terms of financing, a lot of potential in Nigeria because there's a lot of money in Nigeria, and once you find the commitment and there's money available in terms of GDP, there's definitely a lot more opportunity. It's still very donor-driven. I think that came out in one of the, was it the ENN evaluation of financing? Because it only started in 2009. Nonetheless, health workers, for example, are paid. There's a paid scheme. People are paid regularly. There have been authorities in the state, for example, for supply, they will pay for the transport to go and pick up the RUTF, and then the local government areas will go and pick up the RUTF in the state, and then partners kind of help in the supply chain and getting it further. But there's small signs of commitment towards that. In terms of service delivery, not completely mainstream in the sense that it's 1 day a week when treatment is provided, and that causes an overburden to the system, which in turn is one of the key barriers to access as well, where it gets too full and then children do not access some services. Interface is therefore a problem. And then there have been ongoing efforts to get children who are diagnosed with SAM or have symptoms of SAM to be admitted any day of the week. That doesn't always systematically happen. There still need to strengthen it to be integrated into routine services. In terms of the health workforce, great policy in place. I mean, if you look at the theory, there is, from top down, the hospitals, the PHC, there's a very good theoretical or scheme for community health workers in terms of community health extension workers, junior community health extension workers to really be out there. However, that capacity doesn't exist, so a lot of the J2s or the CHWs are pulled into the health facility, which causes a gap at the community level. In terms of supply, still very partner support oriented in terms of there is some efforts from government, but still all of the supply, I think 80% is funded by UNICEF. Nonetheless, there is this sort of effort from the government to pick up from one stage to another, but the main point The main point from the district to getting to the service delivery point is still not covered completely. So partners and ACF has been helping with that. And then in terms of reporting, it's okay. In the middle, because the reporting system is still parallel, but it's quite simple. I mean, the indicators, it's really admissions, the basic indicators that we really need to evaluate programming. It's not overburdened. However, it's still parallel and it's not integrated into the health management information systems, which always takes some time because it's usually reviewed every 5 years, I think. The other experience is Congo, which is another very different case, but I spent some time there recently. In terms of governance, there is no policy for free healthcare at all. Very little investment. That leads to very little investment in the health system. Nonetheless, just to highlight, in terms of nutrition, the National Program for Nutrition was formed ways back, like early 2000, the Pronanut. So there is some momentum in terms of guidelines are in place, and there's a specific program for nutrition, and there is that willingness. There just isn't the funding, which in turn, well, just in terms of financing, there is no payments of salaries. I mean, it's very limited. I met some people who said, we're in the salary scheme, but we get $1 a month. So that has led the financing to be very much organization dependent, donor dependent, in the sense where everybody is paying a prime, you know, the incentives, because if nobody is paid, who's going to work? And there's really a lack of coordination in that sense, linked to nutrition and also to health, since we're all working with the health system. Nonetheless, in terms of service delivery, I will say it's probably the best one I've ever seen, and I visited a few countries doing integration. Service is available 7 days a week. I did see children arrive in the health facility where they were automatically measured for MUAC. So there was this sort of habit of constantly doing or doing screening and providing treatment whenever a case came through or whenever a child came through for a routine consultation. So in terms of the model was okay, but there are a lot of other factors to indicate how the blocks are so interdependent that do not allow it to be sustainable in the long run. In terms of the health workforce, again, there are people in the health facility, but still very fragile in the sense of no payment. And in terms of capacity, there are quite a few doctors, but in very hard to reach areas, difficult to find. In terms of supply, completely partner dependent. The roads are terrible in DRC. We can't even barely get enough RUTF for the demand. So it's all pretty much partner dependent. And in terms of reporting, I've also put in the middle because as much as it's integrated and people are doing it, it's really, really heavy. Like here we're talking about all admission criteria have male, female, all discharge male, female, length of weight, gain of stay, all the different groups, age groups. So we're asking health workers to do that. There are huge reporting systems for the screening and community volunteers in communities, and a lot of expectations where the question is, do we need all that information, or is it something that we want? Who uses it? To try and see how we can adapt it more to the system than to what we are normally doing or used to doing, I guess. Where should we aim to go? I'll go through this one quickly because it'll be more on the practical implications. Yeah, it's like speed. Just strategic implications. The idea is to really do government support. So it's mainly to bring nutrition into health and working through the health system, so linking both. Really trying to promote SAM treatment to be included as a part of the minimum health package. This is a big one, is shifting of partners, a role from implementer to facilitator. I mean, looking at how CMAM was designed and developed through NGOs, that we're not just telling people to do what we know works, but actually taking that and being able to say, okay, how does it fit into your system? How does your health system work, and how can we put in the appetite test and the screening and all of that? Simplifying protocols, implementation, and follow-up. So the simpler it is, the easier it will be to use at a health system level. Transitioning from donor financing to MOH financing, in terms of minimum health package, of which treatment is part of. Practically, just in general, again, identifying new ways of working. We've talked a lot about models, and I've heard models mentioned a lot this morning, but I really believe that the way to go ahead is a process-oriented type of framework, because it's never gonna look the same anywhere, even between health facilities in a district. Coordination of actors is very important, especially in working with a health system where people might be doing things for different reasons, but if we can have a coordinated approach, it will be more cohesive and effective, likely. In terms of design, looking at assessments of the health system, but looking at all the building blocks on how it works for all different diseases. Joint planning and implementation is key. We can't go in and tell people what to do. We can ask and define together. Protocols we talked about, and I didn't want to leave this out because I'm quite passionate about it, and I think it's quite important about community mobilization, but I think it's a topic on its own, and this can be discussed in a separate form, but that has to be included in the design as well. In terms of implementation, just going through the building blocks, still working a lot with authorities and communities because they're part of governance and their ownership is key, so linking to the community mobilization in strengthening governance of SAM treatment, identifying financing gaps, and then the adaptive service delivery process comes back to not just telling people how it has to be done, but asking how could it work? Could you do it 3 times a week, twice a week? What works for you? In what areas? Just on the human resources, there are 2 levels that I think have implications. One is MOH and being able to plan out who are the people who are in place, what are the gaps, and how can we bring those gaps in to strengthen the health system, and maybe through SAM being an opportunity to do so, SAM treatment. There's also the aspect of as partners. This mentality of going from implementer to facilitator is not always so simple because as technical experts, sometimes like it's this way and it has to be this way, and if it's not this way, it's being able to say, maybe it's going to look a little bit different from what I'm used to. And I have 0 seconds. Supply chain, big question. I think it's been raised with the local production and all. Simplifying reporting, so it's always about simplifying everything. Just a couple more slides, quickly. Next steps, just to let you know what's going on in terms of integration with health systems. We've been working on a terms of reference with UNICEF and WHO. It's in draft form. It will be shared in a larger group. We're finalizing, as ACF, the health system strengthening guidelines, but we're also going to be discussing with other organizations to see how to bring maybe a bigger group in towards contributing to it. There's a health system assessment tool that's been tested by UNICEF in East Africa. I think it was Tanzania that was formed, and then Eric has been working on some things on diagnosis as well, so we're going to see how we can bring that together to help guide in the process of assessing the health system. And then I think this is the big research question I want to put there, is to be able to really take a framework and from start to finish be able to evaluate what is the impact and test it in relation to quality of care and coverage. So, to conclude, there lies a significant opportunity ahead with increasing MOH leadership and commitment to SAM treatment to ensure that it's part of regular health services and really moving towards quality global coverage for children. I really do believe that if we can bring that health worker together with that child, we'll really be able not only to treat more cases of SAM, but also to prevent them in the sense that children will have better access to health care. Thank you.